How's it going? Good afternoon, everybody, or good evening, as the case may be. It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast. And there is one place that you need to be right now, and that's right here. It's Fertility with Fink and Friends. I am Fink. You are Friends, live from Colorado Springs, Colorado, where I am the clinical director of IVF services here at CNY Fertility Colorado. And it is so great to be with each and every one of you at this same time every Tuesday afternoon. How's it going? How was your week? We had an awful lot of, we just had a big old thunderstorm pass through here, what with some hail and all kinds of other things going on outside. But it was a little warmer here than it usually is when it has been in the 100 plus 110 degrees. Some places it's 70 degrees here in Colorado Springs, which is quite lovely. So been a little warmer than usual. But again, as always, our thoughts go out to all those folks who are still struggling with the heat and struggling with the lack of power and struggling with all kinds of things, dealing with still the hurricane people, understand people without power. And of course, all our thoughts go out to our friends in Pennsylvania who were just involved with all the scary business happening around the shooting. I would like to say a special hello to a Bama gal lady over here on mine. That would be my mom and dad in beautiful Mobile, Alabama. Thank you for being here. And let's see who we got on the show. Jamie Marie Newton, you are number one here. Thanks for being here, along with VJ and DH7535. Hey to K Royale Shabnam, thank you for being here. Alyssa Marie, Siciliana Melissa, haven't seen you around for a while. Hey to Skittles, nice to see you. A special hi to Tracy in Miami for being here. Hi, Leah. Good to see you as well. And Nurtured Shanna. Jazzy Poo. Brevale. Who we got? Abby Austin, Mel Bell, Sun Fun. Thank you for being here over on the Seance. So we got my Instagram here. We've got LinkedIn and Facebook right here in the middle, along with YouTube. And over here on this side is CNY's Instagram. Hey to Breaking Path. Hi to Brittany, New York City. Good to see you. Number one joining in over here was Tony Danny. Thank you for being here. Max at Play. Breaking Path. We've got Clazer Mel, Savannah. Better with a bat, it looks like. Okay. Oh, Max says thanks. Awesome glasses. Thank you very much. I got some new spectacles here. Just trying to keep it dressed up because really, and I've said this before. There's only certain ways. So when you basically wear scrubs or pajamas to work every day, there's really only a limited number of things that you can do to try to make yourself feel pretty. I can't even. We don't wear cologne to work. We can't wear fragrances because that can be embryotoxic. So for me, it's socks and glasses. That's really all we can do. Socks and glasses. So I try to keep the socks dressed up and keep changing glasses to keep people on their toes. But thank you very much. Let's see. We've got for Eva Sonia. Thanks for being here. And Laura and Tina. And let's see. You help my friends here have a baby in Eureka, California. That's from RG Siri. Thank you. I'm so glad to hear that. Don't think, just go. That is a great handle there. I like that. Hi to Nikita, always Anthony. What a great group of folks here. So T Angela 23 says hi as well. On the Facebook side, we've got Tracy Allen. I've got Lucretia and Marcel. Marcel says, if we decide to come to Colorado for treatment, how likely am I to be treated by you and to be seen by you the day of transfer? Odds are very high. So if you come here for transfer and they tell you it is not me doing the transfer and you would like for me to, all you have to do is ask. And I am always happy to do so if assuming that I'm in the building and if I'm here. Lucretia asks, how long does one need to be off Zepbound before doing IVF? So generally speaking, with that category of medication, we recommend 2 weeks prior to your egg retrieval. So some people will be on the GLP-1 agonist. So that's things like Wegovy, Zepbound, Mounjaro, semaglutide, which is called, I'm blanking on it starts with an O. I can't think of what it's called, but semaglutide. The recommendation, we recommend that you be off of it for 2 weeks before doing the egg retrieval. You're supposed to be off of it for 2 months before doing an embryo transfer, because the medications really haven't been studied in pregnancy. My suspicion is that at some point that recommendation will go away as far as embryo transfer, because you've probably also read and heard a lot of things about people being able to, increasing the pregnancy rates. And we do know that a loss of weight has an effect on both your AMH and on the way your body will process its hormones. And so it may very well, increase your pregnancy rate, although, this hasn't been specifically studied, so it's not something that we can really recommend exactly right now. Alyssa Marie says, do you recommend laparoscopy for endometriosis in addition to meds? My BCL6, which is the marker, is 3.2. They want to treat me with Femara and Lupron for 3 months before transfer. Okay, so let's talk about this because it's important. So the way endometriosis stands in the way of someone getting pregnant is that it can do a bunch of different things. But as far as embryo transfer goes, we know that endometriosis confuses the way the brain is talking to the uterus. And how does it do that? It does that through creating an inflammatory marker in the uterine lining that's known as BCL6. BCL6 is something that we can actually test for. We test for that with something known as Receptiva, which is a non-invasive test for diagnosing endometriosis. Previously, and kind of in general gynecology practice, you need a laparoscopy. You need surgery in order to diagnose endometriosis. But now there is a non-invasive way as well, and that's what Receptiva is. What we know is that treating or suppressing endometriosis with medication for 60 days, it does not need to be 3 months. The data shows us 60 days of suppression is enough to turn off the BCL6 marker so that your odds of achieving a pregnancy go back really to baseline from the very beginning, the very first cycle after finishing the medication. So they're talking about Femara or Letrozole and Lupron. That is one option. I personally recommend using one of the oral medications, which is called Orilissa. And there's another one called Myfembree, and they can be used with letrozole or Femara as well. But they really essentially do the same thing using Lupron. So Lupron is the first medication that we had to be able to treat or suppress endometriosis, and it's been around for probably 30, 25 years, maybe a little bit longer. The generic for that is called Leuprolide acetate. There is what's called a depot form of Lupron, and that's one that lasts for 3 months. So if you get one shot of 3-month depot Lupron, then it will last you for 3 months, and that's why you do the 3 months. There's also a 1-month version of that shot. There's in fact a daily version of that shot, but I'm not sure why you'd really want to do that. When you use Lupron, and you may have heard me say this before, literally what you're doing is that you're pulling the plug on your hormones. You are shutting everything down. You will go into a temporary menopause. And if you are in miserable pain from endometriosis, you have a terrible chronic pain syndrome from it, then being in menopause and being pain-free for that period of time is not a bad thing. It's actually pretty good because even though you get some symptoms from being without hormones, it's better than having all that pain. The two oral medications tend to be better tolerated. So Orilissa is my choice, and it's for 60 days. And do I recommend surgery along with it? I do not. Because again, I do not recommend surgery at all, strictly for endometriosis reasons, or strictly for fertility reasons, I should say. The evidence is pretty clear on that, even though there are many providers who feel opposite, who feel that laparoscopy is very important for anybody with fertility issues, but they've studied this, and the data shows us that it's not something that we should recommend to everybody. If you have chronic pain from endometriosis. So you have terrible periods. Every month you get a period. It is a new struggle in just trying to survive because it's so bad, that pain. Then you may benefit from doing a laparoscopy because they can clean up some of that endometriosis, and that may make you feel better. If what you have, Alice Marie, is silent endometriosis, meaning to say this was discovered just from doing a test because of unsuccessful transfers, and oh, look at there it is. I do not recommend surgery under that scenario. Surgery gets expensive, surgery has its risks, and there is no data that says it's the better thing. Now, again, you will meet clinicians who say, but I love laparoscopy. I think laparoscopy is great. In my experience, everybody should be having a laparoscopy. So every doctor is different. I'm telling you really what the data shows us, and that's where my opinion lies. So if that helps, I hope it does. Hello to Mel Bell. Sun and Fun. Is that real Sun and Fun? Like Sun and Fun in oh, hey, I know who that is. Yeah, it is Sun and Fun, isn't it? Let's see. Cecilia Melissa says, I'm almost 10 weeks with a transfer from Brandis. Outstanding. Melissa, I'm so happy to hear that and hope that you are feeling well. We've had all kinds of people getting pregnant around here. And I can't tell you how much we love getting those stories and hearing about them and seeing the pictures, even of seeing you pregnant. It's just it's a wonderful thing. And speaking of being pregnant, Angela is here as well from the beautiful state of, I always want to say Wisconsin, but I know better now, from Minnesota. Gosh, you know what I learned actually about Minnesota, and I will share this because it's completely an aside, but I'm so fascinated with it. If you order a Bloody Mary in certain places in the Midwest, it's served like a whole meal, which is crazy to me. I've seen pictures of like entire hamburgers and an entire seafood tower coming out of this thing. It's an entire meal, and I have to say, whether you like a Bloody Mary or not, that's a damn respectful way to serve a drink. Don't you think? I'm impressed. Cheryl is there with you guys now, and I think you live in Tampa now, don't you, Mr. and Mrs. Sun and Fun? Hello to Cheryl. I'm so happy to hear you. Ozempic, thank you, Angela, for the word. I couldn't think of it before. Semaglutide, Ozempic, that's what we were talking about. Better with Batty says, or with a bat, I think that is. What do you think about a fresh embryo transfer? I'm nervous about it. My husband and I are 34. So a fresh transfer is always, or a fresh transfer can be an option. At CNY Fertility, a fresh transfer is included in the price of your IVF, but sometimes it is not something that we will recommend for you. And why is that? Because think about it this way. Your body has been in egg-making mode, and when it's in egg-making mode, it may not be as much in getting pregnant mode as it was in trying to make eggs. And so, in that scenario, what happens is the success rate with a fresh transfer is always going to be lower than it is with a frozen transfer. Why is that? Because your body has had a chance to recover from the embryo transfer, or rather has had a chance to recover from the egg retrieval. There are many clinics that do not even offer fresh transfers because the success rate with a frozen transfer is much higher. We believe that people should have the option if that's what they want to do. Now, again, sometimes the hormone levels will tell us this is not a good idea. We don't want you to do it. And there are some people who say, well, I want to do it anyway. Some of us have ethical objections to doing that when we know it won't work because we've really created a life with that embryo. And the truth is that, you've invested an awful lot into making that embryo. We really want it to be able to work for you. So as long as the numbers are okay, in fact, people do get pregnant from fresh transfers every single day. So if you are limited in the number of embryos, it may be that a fresh transfer might not be the best choice because the success rate is going to be higher with a frozen embryo transfer. Colleen says, what should I do after repeated chemical pregnancies? So a chemical pregnancy is where you get a positive pregnancy test. And maybe it starts to go up, but then it starts to go back down before you are able to recognize what we call a clinical intrauterine pregnancy, which means the time at which you do an ultrasound and you see that pregnancy on the inside. That's a clinical pregnancy. If repeated chemical pregnancies, the first thing I would want to know is, well, number one, were these tested embryos? Because oftentimes this can be a chromosomal issue. It can also be an autoimmune issue, and that's one of the reasons that we now recommend Prograf or tacrolimus as a medication for every, I recommend it really for every embryo transfer. It has been studied for those with recurrent pregnancy loss, and Colleen, that would count for recurrent pregnancy loss. So there may be an autoimmune issue there, so I think that's definitely worth talking about. And actually, and I saw a question over here, it came from Liz. When is Prograf started during an FET cycle? So if you're doing a medicated cycle, Prograf is usually started with with progesterone start. If you are doing a natural or a modified natural, it's generally started with the time of trigger. I recommend that you stay on Prograf through the first trimester of pregnancy. And Liz also says, us Midwesterners know how to drink, and you know how to eat a meal with your drink. And that's really the important part. Gosh, what an amazing thing. That and Krispy Kreme donuts, it's not a Midwestern thing, but socks, glasses, full meals with a Bloody Mary and Krispy Kreme donuts. That's what I'm talking about. All right, let's see what else we got here. Hi, I said to Tracy, how long? Lucretia says, I think we answered that one. Tracy asked, do you prefer all keto or Atkins a couple of months before egg retrieval, or is it clean eating whole foods such as low fat, low carb, and low sugar? Dr. Kiltz believes that keto carnivore is the answer because he will describe to you in great detail about how it is anti-inflammatory. I think the thing that, and I will say there is not good evidence that shows that any one diet is preferred. Certainly, Dr. Kiltz has done so much work on that. When you listen to, as he describes, it's very compelling, the evidence that he presents. And I think that the one thing that no matter who you ask, the one thing that we can all really agree on is that, the thing about keto or carnivore, it's high fat, moderate protein, and low carb. The thing that we can all agree on is that low carb, that carbs are pro-inflammatory. So to the extent that you can limit your carb intake, I think you are doing yourself a favor. Hi to Sama. I like that. Mandy says, I did an egg retrieval at the end of May that did not go well. My June cycle began 10 days after the egg retrieval, and I took a break that cycle. The July cycle began last week and went for a baseline on Friday. I only have one ovary, and it had 3 cysts under 20 millimeters. I canceled the cycle because I was worried I wouldn't produce many follicles. Is there anything I can do or meds to take? I want to try again in September. Should the cysts be monitored before then? My estrogen was low at baseline. So when we're talking about cysts, I think this is another, I'm so glad, Mandy, you asked that question, because this is another thing that it's a term that is misunderstood and often gets misused. And so let's talk about what we mean when we say ovarian cysts. In your situation there, you created basically a follicle that probably did not have an egg in it. And so, as you did your baseline, that was measured. Your estrogen level was low, which says it wasn't hormone secreting. So, it was just a little sac of fluid in the ovary, which means there's no egg inside of that. And sometimes the body will do that. It's not uncommon, and it probably really happens, a lot in general. But since most people aren't having an ultrasound at the beginning of every cycle, we wouldn't otherwise know it. It is, in fact, we don't like them to be that large. Generally, above about 14 millimeters is what I think of, because they're taking up valuable real estate, that the other follicles may want to use to be able to grow and to produce eggs. So what do we typically do in that scenario? We can do a couple different things. We can put you on some birth control. Birth control will allow your ovaries to go on pause. It will allow those little cysts to resolve. And usually then within a couple of weeks, we can stop the birth control and then start your cycle. Another option is that we can aspirate those cysts, meaning to say, well, you come to the operating room and we place a little needle in, just like we were going to do an egg retrieval, but we suck the fluid out so that the cysts themselves are gone. Another option is, in fact, you can use a trigger shot. A trigger shot will cause you, because it will also cause those cysts to go away. So that's an option as well. Now that's a different kind. Now, so what can you do about that? Well, usually, I would say I would like you to be on some kind of priming. So that's using a little estrogen, a little progesterone there before you start your cycle, because that will often help to not only suppress the ovary, but it can sensitize the pituitary gland in the brain, and can also help your follicles to grow in a kind of a synchronized, orderly fashion. So that's kind of what I would think about, Mandy. I'm sorry. You know, but that's a different kind of cyst than the other type that we hear about a lot. So a lot of women will get a pain and they will end up having to go to the emergency room for some reason. They have a pain, they're worried about it, they go to the ER. The ER, maybe they do an ultrasound, maybe they do a CAT scan, and they see a follicle in your ovary and they say, oh, you've got a cyst. You've got a cyst in your ovary. Well, there are cysts that can be abnormal in the ovary, but if you're not on birth control, which is suppressing the function of the ovary, every single month you are going to develop a cyst because you're developing a follicle. As that follicle grows, it gets bigger and bigger and bigger until ultimately people say, well, then I ruptured a cyst. Well, did you rupture the cyst or did you in fact just ovulate? When you ovulate, your ovary releases that egg. And that's like a car leaving a garage. It leaves behind an empty space. Your body hates empty spaces. And so what does it do? It fills that space with fluid. And in some cases, it fills that space with blood. That blood is what's known as a hemorrhagic cyst. So it's literally a bruise on the ovary. And it can be painful because just like a bruise anywhere else can be sore. But the other thing it's doing, the ovary is a little, it's about the size of a walnut. And it's got a capsule around it that's pretty strong. It's pretty inelastic, but when you're filling the space inside of it with blood, it puts some stretch on that capsule, and that absolutely can be painful. So a lot of times folks end up going to the hospital and they're being told that they have a cyst or a cyst that ruptured. And really what they're experiencing is a normal physiologic part of the ovary. And so I just feel compelled to talk about that because then, forevermore, these women will then feel like they have to report as part of their medical history, oh, I have ovarian cysts. Well, everyone who has ovaries will at some point have an ovarian cyst because that's how ovaries function. They create those cysts, which are a little sac of fluid. It's an egg house. It's a follicle until it reaches the point where maybe it gets big enough that then it just collapses. Maybe you ovulate and release that egg, but this is what the ovary does. This is its job. This is how it gets its ovarian paycheck. So Liz says, I missed last week, so I've been thinking of question for 2 weeks. How do we request a certain provider to do our transfer? So no matter what location you're in, so sometimes there are specific providers who are at your location who are available that day. Sometimes they are not, but we at CNY really want to do our very best to try to make your entire experience something that is a good one. So if you have a request for a particular provider, we just want you to ask for it. Simply ask for it. Sometimes if you're, let's say, going to Syracuse and gosh, you have your every hope and dream set on Dr. Kilt's doing your transfer whenever he can. I know he loves to do that and would be happy to be there with you. Again, just ask, or you really want to see Dr. Corley because he was so nice on the phone. Just ask. We do everything we can to try to help you with that. What's a good endometrial lining? Is there too thick? We do not think there's too much thickness really for an endometrial lining. Once it gets above, about 20, then I'm going to wonder, 20 millimeters or 2 centimeters, I'm going to say, is there something else going on here? Is there a polyp in that lining? When was that uterine cavity evaluated? Because I really want to make sure. But let's say it starts at a nice normal thin lining of 4 or 5 millimeters and it grows to 18. Generally speaking, I'm okay with that. We're looking for what's called a trilaminar lining, if possible, which means it was appropriately estrogenized. How long should I plan to stay, and when can I fly home? So, after an embryo transfer, we like you to take it easy for about 2 days, which means we don't want you on bed rest. It means we just kind of want you sitting around. You can walk around, you can do some shopping, you can do some sightseeing, you can have a good time, you can go out to eat, you can live your life, you can walk up steps, you can take a shower. I always tell people, and you can't bounce an embryo out, you can't pee it out, you can't sneeze it out. Even if your husband's driving, you can't bounce it out in the car. They're good and sticky. They tend to stay there. Our species is not so fragile that we have to worry about things like that. But you're not supposed to eat raw things. You're not supposed to have deli meat. Did you know that you're not supposed to have deli meat in pregnancy? The reason for that is because it doesn't always, but it can contain a bacteria that's known as listeria. And listeria can wreak havoc on a pregnancy. And so what I tell people is that, all right, so if you really feel like a ham sandwich, put a piece of cheese on it. Melt the cheese. If it's hot enough to melt the cheese, it is likely hot enough to kill the listeria. And then you can eat all the deli meat you want. You can travel after a transfer. A lot of people do go home that day. I don't think there is I've never seen any evidence that that flying on an airplane or a prolonged, that a car ride is problematic. But we do like you to stay extra hydrated. Want to keep your blood flowing, keep you moving around. Prolonged, car rides can increase your risk for things like blood clots and stuff. So if you keep drinking, you keep yourself hydrated, you're probably going to be stopping more frequently to use the bathroom, keep your blood moving around, and that is a good thing. Let's see. Mrs. Ann Smith says, I just did my last Lupron depot shot a week ago. When do I need to reach out to start my transfer? Okay, so you were on Lupron. The question is, when can I start a transfer? It depends on which Lupron you used. Was it the 1 month Lupron or was it the 3 month Lupron? If it was the 1 month Lupron, we know that shot is going to last you for about 4 weeks. I would recommend at about the 2-week mark, you reach out and say, hey, I got my shot 2 weeks ago, so I'm going to be ready to start my cycle in about 2 weeks, and let them give you the instructions from there. If it was the 3 month shot that you got, I think you can wait until about 2 months and 2 weeks, or rather until you're about 2 weeks before you're going to finish there. Sincerely, Alyssa says, I had monitoring done day 4 and I only have 4 follicles. Hey, you ask a really good question. So just because your early cycle count, your antral follicle count is what we call that, sees that there are 4 follicles, that doesn't mean that you are only going to develop those 4 follicles. So when we're stimulating your ovaries for IVF, we're going to be trying to recruit eggs from all throughout the ovaries, not just from the visible follicles at that time. So the answer is yes, there absolutely is hope. Brittany, New York City says, I'm 23, low AMH. I have 1 blocked tube. After 3 egg retrievals, I was only able to get 2 blasts. Would you advise transferring both or just 1? Brittany, at 23, the guidelines would say we want you to transfer 1. Why is that? Well, because despite what some people wish for, we don't want you to have twins. Twins significantly increase the risk for pregnancy complications, for preterm birth, and for even lifelong injuries in the babies. So we want you to have 1 healthy baby at a time. We follow some guidelines known as the ASRM guidelines, the American Society for Reproductive Medicine, and they tell us that at 23 years old, 1 embryo, especially as a blast, 1 blast would be what we recommend, because even though you've had a hard time making embryos and getting eggs, the odds of you having normal DNA in your eggs is very high. So the odds of you achieving a pregnancy with even a single embryo is also extremely high. So fingers crossed there. Both fingers crossed there, my friend. How about that? Prolactin. I did my test at LabCorp. It came back at 43. The next day I went to Quest and did the test again, and that came back at 20. Which number do you prefer the prolactin to be at? We prefer prolactin to be normal. Now, there is some variation in timing of the prolactin hormone. Prolactin can also be affected by breast stimulation. So let's say that you had intercourse that morning and had a lot of breast stimulation and had a lot of uterine stimulation, and then went and had your blood drawn, your prolactin may be elevated. So usually what we recommend, 72 hours with no breast stimulation, and do the test first thing in the morning, because it can go up a little bit later on during the day. So we're really looking for certainly the lower number, which would be normal. Shanna says, I've been experiencing a painful endometriosis flare-up and will be getting checked for cysts before starting a retrieval next cycle. If there are no cysts, should I be concerned about moving forward with retrieval? So as long as there's no, big endometrioma in the ovaries, then doing an egg retrieval is fine. I think that is a good thing. We really would want you to suppress that endometriosis, nurtured Shanna, before you do an embryo transfer. But I would always recommend that you, as soon as possible, get your eggs and make your embryos, because the earlier you do that, the younger you are when we do that, the greater the probability that those eggs are going to be normal and create nice normal embryos. So no, as long as there's no, and even there's plenty of people who have endometriomas, collections of cysts in the ovaries, that we just kind of work our way around, because I do not necessarily recommend that you go and do a surgery to remove an endometriosis cyst, because when you do that, you will almost certainly decrease your AMH. It will absolutely affect your ovarian reserve. So really, if we can leave the endometriosis in the ovaries, would just let us deal with that from the BCL6 standpoint before you do your embryo transfer. Ariel Eden, good evening to you. I'm taking Provera before egg retrieval. What is that for? My orders are estrogen and Provera before egg retrieval. So what I like to do is I do 10 days of estrogen, of estradiol. Usually it's once in the morning, once in the evening. Estrogen is priming the ovaries. Estrogen is talking to the ovaries and telling them, hey, increase your blood flow. Hey, let's see if we can't juice up the eggs that are hanging around close to the surface so that when it comes time to stimulate them, maybe we'll do better with that. It also helps by tuning in the brain to the hormonal situation there. And when you get estrogen, we want to balance that out with progesterone because those two things, they're sisters. They're sisters, but they're kind of on the opposite sides of the room. So if you've got too much of one and not enough of the other, that can cause you some hormonal problems. So when we do that estrogen, we do the progesterone with it to keep them nice and balanced. Now, the Provera, usually what I do is I have you stay on the Provera because Provera functions as what we know of in IVF as an antagonist. And an antagonist is what stops you from ovulating. We're giving you all this medicine, telling the ovaries, pump up the volume, girls. We don't want you to release that egg until we are coming for it. We want those eggs. We don't want them going loose in your pelvis there because they're not going to do us any good, right? So Provera is a very inexpensive antagonist. It's one less shot, and then sometimes it actually works even better. So the only downside to using Provera as your antagonist is that you can't do a fresh transfer because it's progesterone. So you're messing with your uterine lining there, and that will keep you from getting pregnant. So wouldn't want you to do that. But that's the reason using the Provera with the estrogen as a priming keeps them balanced. And in many of my protocols, I have you stay on the Provera because you can use that as your antagonist. Are meds given to bring down the prolactin, since such a huge difference between the two results, which will be best to be on just in case. So usually we use cabergoline or Dostanex. And we do want to normalize that prolactin because if the prolactin is elevated, it can interfere with the way the hormones talk to each other, and it can interfere with your egg stimulation. We also want that prolactin to be normal, especially around the time of embryo transfer, because a high prolactin is also associated with messing up the uterine lining and increasing the risk of miscarriage. Let's see, Shabnam asked, do beta numbers matter? Well, yes, because the beta HCG is our pregnancy test. And so we look to see that. Does the first number matter? No, not so much, not so much. But subsequent numbers do make a difference because we expect to see that beta HCG, or your pregnancy test, increase. We expect to see it double in most 2/3 of normal pregnancies in 48 hours. So those are the kind of numbers we're looking at there. Fijay says, I am on Depo-Lupron due to a laparoscopic myomectomy in September. How soon after can I do an FET? Will be using my partner's frozen embryos. Can I do my own egg retrieval at the same time? Well, so a lot of surgeons will, so you've got a fibroid in your uterus there, and some surgeons like to use Lupron, which can decrease the volume of your fibroid there by about 20%. So it can, some people say it makes the surgery actually a little more difficult because it affects the tissue planes, but it does shrink the fibroid. So, because you're having your uterus incised and the fibroid taken out and then the muscle of the uterus sewed back up, there is a recovery period there before you could do an embryo transfer. Most surgeons will say about 6 months after that myomectomy before you want to think about trying to put something in the uterus. Also depends on how big the fibroid is and how much work really they have to do. Can I do my own egg retrieval at the same time? You could do a stimulation And then basically what would amount to kind of be doing a fresh transfer, but with your frozen embryos that came from your partner. Sounds like a reciprocal IVF. Yeah, you could do that. A special hi to Zenaida, also in Miami. Thank you. And thanks for the compliment on the glasses. Equestrian, nice to see you. Haven't seen you around. Actually, I think you were here last week. Andre says, best time to test for AMH levels. So the AMH is the anti-Mullerian hormone, and even though it can have some variation during the menstrual cycle, we do not have a specific time that we tell you that you should do it. So, in general, unlike an FSH, if you're using your FSH as a predictor, then we like to see an early cycle, like a day 3 FSH. But AMH, really, you can test it anytime during the cycle. And it should be, again, there can be some variation, but it should be kind of mostly the same. Let's see here. Jazz Diaz de Leon. Can you please tell us about IVF and fibromyalgia? So fibromyalgia is a difficult disease because it's kind of a moving target on its definitions. I am no expert on fibromyalgia, but the good news is that I am not familiar with any data that shows us that fibromyalgia patients are going to have a harder time with with ovarian stimulation to retrieve eggs. Folks with fibromyalgia may feel more sensitive to hormones sometimes, and certainly with pregnancy as well. But from an IVF standpoint, being able to stimulate your ovaries, there should not be a correlation between the diagnosis of fibromyalgia and things like egg quality or AMH. So that's the good news. Is there bad news that goes along with that? Well, it depends on how significant your fibromyalgia is. There's some people who are really debilitated by fibromyalgia, and that becomes, it's a difficult disease to deal with because there aren't a lot of great treatments. Now, in my opinion, I believe that there is certainly something autoimmune with fibromyalgia. And so for folks with fibromyalgia, I tend to use the little higher doses of our immune protocols. So I might immediately go with an immune protocol level 3 instead of with a level 2 for somebody who didn't have any other recognizable problem. Let's see. Hi, doctor. You did my surgery today and I feel great. Oh, I'm so happy to hear about that. That is fantastic. Hope you get to enjoy some good dinner here while you're in town. How effective is a PRP for low ovarian reserve? This comes from Danny. Danishar, actually. Well, so ovarian PRP is considered experimental. Personally speaking, I am a believer. I think it can help. We do see some people's AMH levels go up after a PRP, but there is no recognized test that we can do specifically to see what that PRP is doing inside your body. Many believe that it's the actual act of placing the needle in and putting some fluid in, even though it's your own growth factors, your tissue factors that are helping the ovaries. I believe it also significantly helps with egg quality as well. So I am a believer. There are lots of folks here at CNY who believe in what's called high volume PRP. And that's where you take that PRP, that platelet rich plasma, and instead of injecting it into the ovaries, you put it in a syringe and you squeeze it into the uterine cavity, let it run through the fallopian tubes, assuming that your fallopian tubes are open and that it then bathes the ovaries. That is not my preference, but Dr. Verdialis is an expert in high volume PRP. But as far as intra-ovarian PRP, I feel pretty good about it. Let's see. How come we transfer 2 good 8-cell embryos today we got our lab results that the beta HCG is negative. We are at age 44. What do you suggest? Well, so at 44, if you have an untested blastocyst, we know that your odds for pregnancy with those embryos are less than, at 44, it's actually about 1%, maybe even less. So the only way to improve the odds of pregnancy with your blast, and that's based upon the egg quality, that's based upon the DNA that came from those eggs at 44 years old, it has a much higher probability of being unstable or not normal than it does of being normal. So even though you had a couple of good-looking embryos, that is talking about a beauty contest. They were good-looking embryos, but they may not have been normal embryos. The only way to increase the probability of a pregnancy in that situation is to do PGT testing. Because if you can make an embryo that is chromosomally normal or euploid, then we know you have a 65% probability of getting pregnant with that embryo compared to about a 1% probability with an untested blast at 44. Now, how likely are you to be able to make a normal embryo? Well, there's lots of things that we can try to do to improve egg quality, but if we're really talking about walking away with a high probability of pregnancy, it would be because we had an embryo that we knew was chromosomally normal. That, unfortunately, is probably why it didn't work. But our thoughts are with you and our fingers are crossed. Back over to Facebook. By the way, it's about 45 minutes after the hour. We got about another 15 minutes here on Fertility with Fink and Friends. I am Fink and you are Friends. Thank you so much for being here like every Tuesday. Nice to see you guys. Ashlyn says, I got my BFP yesterday after transferring 2 day 3 embryos on 7/5 in the Syracuse location. My BFP. I should know what that means, Ashlyn, but I'm blanking. But I guess it's good news because I think you've got some happy clapping faces there. Marcel says, how many embryos will you allow someone to transfer maximum? Recurrent miscarriages, tried donor egg blast and didn't stick. So again, there are guidelines there, Marcel. What we recommend, it depends on whether they're day 3 embryos, it depends on whether they're blasts, and it depends on where those embryos are coming from. So let's say that you have 2 embryos that came from donor egg. So the recommendation would be that you transfer 1, especially with a history of recurrent pregnancy loss. It probably would be 1 embryo, but would we allow you to transfer 2? Yes, we would. So in most cases, unless we really believe it's going to harm you, like overtly hurt you, for instance, then we will let you do it. There's a form that you sign saying it's against medical advice. It's not what we would recommend for you, but you can choose to do it. So, I've seen someone, well, I had a loss of twins at 16 weeks due to an incompetent cervix or for whatever reason. Now I've got euploid embryos and I want to transfer 2 of them. Well, transferring 2 euploids is absolutely against the guidelines. And in that scenario, I, as a clinician, might be putting myself at risk liability-wise because that's the wrong thing to do. You already lost 2 twins at 16 weeks, so why am I going to put you in that position again? It may be negligent on my part. So there are some situations where we might say no, but generally speaking, we try to accommodate your wishes. If you came in and said, I've got 4 euploid embryos and I want to transfer all of them, we will say no because that is just that's a potential catastrophe, and we don't want to be any part of that kind of scenario. Tracy Allen says, I have a follow-up phone call with you in a couple of weeks. Awesome. How far is Colorado Springs booked out for egg retrieval? Usually, if you're already a patient here, then, probably by the time you have your next cycle, we can get you started. Just got to make sure that financial is clear and that the meds can get in your hand and that your monitoring is set up. But usually pretty quickly, sometimes a day is booked out for stem starts. But again, if you talk to me, I usually like to do a little bit of priming, which gives you kind of about a 2-week jump on when you would start your stimulation, so you can get on the books really without a problem there. And FETs, I don't think we're booked out really much at all. Looks like TC says, this is so interesting and awesome. Thank you. I appreciate that. Rocio says, how far? Oh, I think we just saw that booked for egg retrieval. Again, once you have your, and you know, the biggest weight at CNY is because of the demand, is getting that initial appointment, and we're kind of doing our best. There's been some restructuring of the teams and the way these phone calls are assigned to providers to try to get folks in more quickly from the time they make their original consultation, their original appointment. Now, if you have a request and you say, well, I really, I only want to speak to Dr. Banerjee in New York, who's a lovely man. I would get it. I certainly understand why you only want to talk to Dr. Banerjee. He's also a great cook, I will have you know. Then, there may be a longer wait because I don't know what Dr. Banerjee's schedule is like and how often he's doing consults and how often he's doing retrievals and so forth. So if you have a specific request, sometimes it takes a little bit longer. But that's where the wait is, much more so than anything else. Once that's gone, usually by the next cycle, you can actually start your IVF. Alicia says, let's see. I was hoping to get your insight on modified natural transfers after 4 unsuccessful medicated cycles, 35 secondary infertility, no known issues because of hyperthyroidism. No known issues because hyperthyroidism, ERA laparoscopy, HSG. All good, not PGT tested embryos. Well, all right. So let me tell you what my general overview of that situation would be there, Alicia. First thing I would want to know is, okay, when was the last time uterine cavity was evaluated? I'd want to make sure there's not polyps, fibroids, scar tissue, something on the inside that's trying to prevent your beautiful, perfect embryo from being able to implant. Secondly, I would want to know that, gosh, you don't have endometriosis. You did an ERA, not such a great test. Oh, well, you did a laparoscopy, and if they didn't see endo, then probably feel pretty good about that. So now I start thinking that, okay, there's one of two things here. This is either an embryo issue. These were not PGT tested embryos. So don't know if these were day 3 embryos, because if they were day 3s, then we really don't know how well they're going to do. We don't know how they're going to perform or how they're going to grow. If they were blastocysts, then I would suspect, it kind of depends on your age. If they're untested blasts, if you're 35 or under, there's about a 40% probability that an untested blast is going to get you pregnant. And if you've done 4 of them, that tells me, well, something else is probably going on there, and I want to know what it is. Then we start thinking autoimmune type issues, and that's one of the reasons we use our immune protocols. Specifically in that scenario, it's what's called recurrent implantation failure. Pardon me. And so that's one of the things that Prograph is designed to treat. So we would look pretty carefully at all those variables and see what's going on. Melissa says, does it matter to do the longer Lupron or the shorter Lupron depot for suppression before the next FET? Well, again, the data shows that 60 days is all you need for suppressing endometriosis before doing your embryo transfer. So in that scenario, I would say I would do the shorter acting, the 3.75 version, because you can do it once and then a month later you do your second shot and then you're done. So as opposed to the single shot Depo Lupron rather, at the 11.25 milligram lasts for 3 months. So you can do a 2-month therapy. 2 months is as good as 3 months. There is no data that shows, well, if 60 days is good, then I want to do 120 days because that should be twice as good. 60 days is all you need to shut down the BCL6. I am 39. Does CNY transfer 2 frozen embryos? Yes, we will. We generally ask you to try 2. adhere to the guidelines. And at 39, 2 embryos may be very appropriate. Brooke says, might have been asked, but do you usually recommend FET for endometriosis and doing suppression before? Yes, I would. If you have known endometriosis, then I would strongly recommend that you do the endometriosis suppression before you do an embryo transfer. It's very dramatic what effect it has on improving the outcomes by using 60 days of suppression. So best of luck there, Brooke. Jacoby says, which procedure do you think is best for a 35-year-old woman who had her tubes clamped 7 years ago and has 3 kids and gets cycles regularly? Well, if the tubes are blocked, if your tubes were tied or clamped or burned or in some way obscured so that sperm and egg can't meet one another, if you had permanent sterilization, tubal sterilization, then IVF is your only option. Because it doesn't involve the tubes. We get the eggs from the ovaries. The sperm is given to us by the male, and the embryos are made in the laboratory and placed back inside the uterus. So we don't need to worry about the fallopian tubes. So that is the situation there. Jeanette's asking, I had my first FET and I got an ectopic pregnancy in late May. So that's a tubal pregnancy, presumably. I had surgery to remove it. My HCG level is now 0. And my cycle hasn't come back. Is there any way I can induce it to start an FET? So I would recommend you get that first, well, that was from May, late May, June, July. It should probably come any time now, I would guess, as long as that beta is 0. But there are situations where we can, use some Provera to cause you to get a period, slough that lining off. But it may just be that you're a little bit late there because your body had gone through all that trauma and is still trying to, kind of recover. Let's see, Delaney, sorry, I'm mispronouncing the name, is a heterogeneous myometrium, myometrium always pathological? Does it affect implantation? So I think what you're asking about there is when we see that the myometrium or the muscle of the uterus it has an appearance of adenomyosis. Adenomyosis is where the glandular lining inside the uterus takes a dive into the muscle. That's what adenomyosis is, and it can affect implantation. The thing is, you see that adenomyosis can also be a normal variant in people, and so it's really hard to say the extent to which it will interfere with implantation. If in doubt about the severity of adenomyosis, an MRI of the uterus, an MRI is the definitive test. For Eva Sonia says, I had a failed IVF in April. How do you bounce back from that and go to another round? The hard thing about this whole damn process is the roller coaster ride. So physically, your body will do it. And I would tell you there, my friend, that in most cases, we really can look at a situation, especially one that didn't work out the way we want for it to, and say, I think I understand what went wrong here. We probably have the ability to look critically at that scenario and say, okay, this was, I think if we adjust your stimulation, for instance, we may get a very different outcome. Now, sometimes it is reading the writing on the wall. It may be that, we have folks who have an extremely low AMH level, or who are menopausal, or who have a premature ovarian insufficiency, who do a cycle and don't get a very good outcome, and that's because they're just not going to get a very good outcome. So, but I think we have the ability to look at these things and say, this is what I think it was, and this is what, if anything, we can do to fix it. I tend to try to look at that very scientifically. I try to look at that not by using my professional judgment, but really by looking at statistics and by looking at numbers and trying to piece together a puzzle that shows us where we need to move next. So it's not guesswork. we really try to do this based on the best available evidence. And so I would say I think it's worth talking to us about, how can we improve it? But meanwhile, the roller coaster sucks. This is what I always say. You get on that damn roller coaster, it's flapping your head around, you end up with a concussion, you're nauseated, the person behind you barfed on you, and so you just can't wait to get off that train. Fortunately, in most cases, I can't say all, but certainly most cases, we know that train is going to pull back in the station, and God willing, you'll be able to get off of it with a lovely parting gift in your belly, and that's a baby. We've got about a minute left here. Let's see what we can do. Elmosins. Hi, I am currently getting ready for an FET. I stopped my birth control on 7/12, started Lupron on 7/10. Is it normal to have a period before starting patches? This is a medicated cycle. Well, you were on, so there's two reasons. You were on birth control, which meant you were getting a hormone level here. You stopped that birth control, which meant the hormone level dropped off, and that is the body's signal to have a bleed. Additionally, if you're using Lupron in that cycle, that's telling the brain, turn off the hormone. So it's doing the same thing. It's causing a drop in that hormone level. So a bleed is the expected outcome. So, yep, you're in A-OK shape there, my friend. Don't you worry. Hey to Ashley Harmon, with a P4 right before trigger being a 3.5, is there a zero chance of a fresh transfer? So I would say there's pretty much a zero chance of a fresh transfer working. Yeah, we look for that progesterone number to be a 1.5 or below. The progesterone controls your implantation window. And so as it gets closer to 1.5, that window gets narrower and narrower until at 1.5, the window's closed. So at 3.5, I think that would be way too high. I would tell you, you're going to waste an embryo. Ashley, don't do it. Maria King says, I have my FET with you on Friday. I'm nervous because my ultrasound from Friday, I guess last Friday, showed mild fluid in the cul-de-sac and small fluid in the endocervical canal. I don't think that's a problem. I think you'll be okay with that. You're on Benadryl. Yeah, Benadryl will help to make some of that fluid go away. Fluid in the cul-de-sac doesn't matter. If there's some fluid inside the uterine cavity, that's something that we can oftentimes address at the time of transfer. It's just a little bit, then sometimes we'll just suck it out. If there's a lot of fluid, well, then that usually means that the environment may not be very healthy or comfortable for your embryo, but from what you're describing there, I think is going to be okay. Guess what, folks? We're out of time. And gosh, like every Tuesday, I am so happy to be here with you. I hope you'll have the chance to come visit us here in Colorado or at any of our CNY locations because this is what makes us happy. And look at the sign behind me, which is backwards, I think, for everybody there. But the last word on that thing is hope. And that is tomorrow the sun rises and there is hope for something new. There is hope for something different. Lead every day forward with kindness. We do not have enough kindness in this world. And anything that you can do kind for another human being means that you are a blessing on this earth. Lead forward with love. Share that with each other. Thank you so much for being here. This is not the book of your life. This is merely one chapter. And what are we doing? We are here to rewrite it. So until next week, I'm Dr. Randy Fink from Colorado Springs. Good night.